All right. Hello, everyone. We're about to start. Before we go ahead, we're going to have the panelists present themselves before we present our guest speaker today. First, I'm Ulrich Sidney Kanmunye. I'm the president of the Association of Future African Neurosurgeons and equally a research associate at Harvard Medical School. We're happy to have you today. I'll be calling upon the panelists based on the list I have here. Dr. Alexandru Budu, can you present yourself, please?
Hi, everyone. My name is Alex. I'm a spinal fellow working at the Cambridge University Hospital, and I used to work at Sheffield with Mr. Ushewokunze.
Well, thank you so much for being here today. Arif?
Yeah, hello. I don't know if you can hear me. Sorry, hello everyone. My name's Arif. I'm a neurosurgical trainee, currently training in Hull, but I also used to be a trainee of Sheffield. So I've also worked under Mr. Ushewokunze before.
Well, thanks. CBMJ. CBMJ? I'm not sure.
Hello, everyone.
Hi.
Celestin Bilong, fourth year medical student, Cameroon.
Sorry, what's your name, please?
Celestin Bilong.
Oh, okay. Thanks, Bilong. Next up, Daniel Safari.
Hello, everyone. I'm Daniel Safari from Democratic Republic. I'm actually the coordinator of Incision DRC and a medical doctor. I'm glad to be here this evening.
Well, glad to have you from DRC, Daniel. Thanks. Chimuka Kuma, please present yourself.
Hi, everyone. Yes, my name is Chimuka Bea from University of Zambia, and I'm a member of AFAN. Thank you.
Thanks, Chimuka. David Orishdale.
Hi everyone, I am David Orishdale from Rosham, first year medical student in the North Caucasian Medical School. I am equally a member of AFAN and a member of the communication and operation team in AFAN. Thank you.
Well, thank you very much. And Dale Genevieve.
Hello everyone, my name is Indala Genevieve, fourth year medical student in the University of Boya. I'm also a member of communication and operation team of AFAN. Thank you.
Thank you, Ndale. Gideon Adegboyega.
Hi all, my name is Gideon Adegboyega and I am a fourth year medical student at Barts in London. Nice to be here.
Thanks. Ola Romini.
Hi everyone, my name's Ola. I'm a neurosurgical trainee based in Sheffield and so worked with Mr. Ushewokunze as well and looking forward to the talk.
Oh, thanks. Rosalind de Koning. If you're speaking, I think your mic is on mute. Maybe not.
Warwick, I think she just texted in the chat.
Oh, okay. Oh, I saw that. Yeah, so Rosalind is a fourth year medical student at the University of Oxford. Well, thanks, Rosalind, for joining us today. Ruvarashe Ushewokunze.
Hi, I'm an incoming medical student for the University of Kiel. Yeah, quite interested to see what's going to be about today. Thanks.
Well, glad you could join us. Stan Mashamba.
Hi everyone. I'm a second year neurosurgical trainee at the University of Zimbabwe College of Health Sciences. Happy to be here.
Oh, glad to have you as well. Nyararai Togarepi. Can you please unmute and present yourself? Okay, I guess it's not possible. Well, thank you all for joining us today. Now we'll go ahead and present our guest today. Please mute your mic, and if you have bandwidth issues, please cut your video feed. That will help you follow the presentation all the way through. So today we're blessed and honored to have Mr. Shungu Ushewokunze, who is an adult and pediatric neurosurgeon, works at the Royal Hallamshire Hospital and Sheffield Children's Hospital in the United Kingdom. He studied medicine at the University of Zimbabwe and got his MBBS in 1997. He worked as a houseman in Bulawayo, Zimbabwe, before moving to the UK. Mr. Ushewokunze then went on to complete his basic surgical training in Newcastle upon Tyne, followed by neurosurgery training in Birmingham. He then undertook a pediatric neurosurgery fellowship working with Virginia Meixner at the Royal Children's Hospital in Melbourne, Australia in 2011. Mr. Ushewokunze has been working as a consultant neurosurgeon in Sheffield since 2012, and his interests include low-grade glioma surgery in eloquent regions of the brain and epilepsy surgery in the adult practice. Our guest today is passionate about pediatric neurosurgery, and he has a keen interest in hydrocephalus, Kyrie malformations, and Moyamoya syndrome management. We're happy to have you today, Mr. Ushewokunze. Please unmute your mic and start your presentation. Thank you.
Thank you. Thank you very much for inviting me. Let me share my screen. So today's talk is on genomics in low-grade gliomas. This is an interesting topic. It really is at the heart of low-grade glioma treatment currently. The way that low-grade gliomas are being treated in the world right now has changed so much in the last 5 years, and the genetics of the tumor have been the determinants of this. So what I've prepared is a talk looking at a neurosurgeon's perspective on the role of genomics in the management of low-grade gliomas. Sorry, I need to get rid of this. Hold on. That's fine. So that's the aim. So I'll cover a few topics. Well, the objectives of the session really are to discuss why genetic markers are important, to review the genetic markers that are used in the clinical management of low-grade gliomas, to go over the updated 2016 classification of low-grade gliomas, and then to give you an overview of our historical management of low-grade gliomas in Sheffield, but applying the molecular information. This will then lead on to a short discussion about the relevance of this topic in the African setting. And we'll also have a chat on the future directions of treatment. To start off with, there's a survey that's been sent out, and there are two questions that I've asked. Really, first of all, to understand how available molecular diagnostic services are available in your area, and also then to look at the challenges that people may be facing locally in obtaining a molecular diagnosis. I've been part of a group called the Society of Neuro-Oncology Sub-Saharan Africa, SANOSA, I think it's called, and it's to do with neuro-oncology in Africa. And when we look at neuro-oncology management, it's not easy to just apply treatment paradigms which have been developed elsewhere in the world in the African setting. So I think it's important to look at the context, or to look at this topic in context. So I hope you all get the opportunity to answer those questions, and then we can discuss them later. So lower grade gliomas account for 15% of all gliomas. For the medical students, glioma refers to a tumor in the brain. They occur in approximately 1 per 100,000 person years, and the peak incidence is between the 3rd and the 4th decade of life. Most of these tumors present with seizures in adults, and sometimes they present incidentally, particularly now that MRI imaging is a lot more available and people are being imaged for other reasons. They may pick up that they have an abnormality. Generally speaking, the outcome of a lower grade glioma is better than a high grade glioma. And when you look at the 5 and 10-year relative survival rates in a diffuse astrocytoma, you're looking at a survival of 47% at 5 years and 37% at 10 years. And in an oligodendroglioma, 79% at 5 years and 64% at 10 years. This is very, very different from the median survival of 12 to 15 months in a high-grade glioma. There are a number of familial syndromes, and when you take a history from a patient with low-grade glioma, it's very important to ask the question whether there's a history of brain tumors in the family, also whether there's a history of other cancers in the family or any other syndromes. And from time to time, even in my own practice, I've come across people who have had some of these syndromes. I've outlined a few here, something called the Lee-Fraumeni syndrome, which is associated with the P53 mutation. This is a tumor suppressor gene. And this syndrome is associated with breast cancers, brain cancers, and soft tissue sarcomas. There's a dominant mode of inheritance, and you can get all types of gliomas with this. The other syndrome that you need to be aware of is Lynch syndrome. And you can see the genes there, the MSH2 and 1 and 6 genes. Again, it's a dominant mode of inheritance. And this is associated with gastrointestinal cancers, endometrial cancers, and other cancers. Neurofibromatosis is a neurological syndrome that we see quite commonly in neurosurgery practice. And certainly neurofibromatosis type 1, there is an increased association with gliomas. And these patients can have neurofibromas and schwannomas. Olliers disease is another condition that you should know of. So the first question is, are genetic markers important? Historically, we've looked at pathology, and when you stain the tissue, we can usually tell the difference between what looks like a high-grade tumor and what looks like a low-grade tumor. But what we know is that even though low-grade tumors are so-called benign, they do grow at a rate of 2 to 3% per year. And there are volumetric MRI studies which have been undertaken, which clearly show this. And at some point, all low-grade gliomas will transform to a higher grade. So it actually is a malignant disease, but that is very, very slow to progress. Historically, and by historic, I mean when I was training when I was a neurosurgery trainee, when I first encountered low-grade tumors, the information I received was that it really didn't matter whether you simply observed the patient with MRI scans, whether you did a biopsy or did surgery. It really had very little influence on overall survival. Later in my training, the message changed to say, actually, if you did surgery and you gave radiotherapy, you could improve progression-free survival, but you wouldn't impact overall survival. And I have certainly one example of a patient I looked after who had a low-grade tumor. And he was a homeless man, and he came in after a seizure. He had a low-grade tumor, had an operation. And I had the job of informing his diagnosis. And his diagnosis was that of a low-grade astrocytoma. It was a gemesocystic astrocytoma, I remember. And I said to him that he should be pleased because it's not a high-grade tumor. Anyway, he wrote me a letter because he was in hospital for so long because of social reasons. And he couldn't understand why I was saying that he should be pleased. Unfortunately for him, he didn't survive for more than 3 months. And at that stage, it just didn't make sense. And we now know that a histological diagnosis provides a limited understanding of the behavior of these tumors. And genetic markers certainly improve the diagnosis, help us explain things better to our patients, and provide patients with better treatment options. So even though I'm a neurosurgeon, not a pathologist, I spend a lot of time talking about genetic markers to patients with low-grade tumors. Now, the old 2007 classification, and even in the current classification, traditionally grade 2 tumors are the low-grade tumors, and then so grade 1 and 2 are low-grade tumors, and grade 3 and 4 are the high-grade tumors. But the way we look at things now is actually we group the grade 2s and the grade 3s as lower grade tumors, the vast majority of them separate from the grade 4s that are high grade tumors. There are exceptions to this. When you look at the slides under the microscope, we're looking at the markers of mitosis, the cell shape, and whether there's vascular proliferation. So those, the features, the morphological features are what are used to distinguish between the various tumor grades. In 2009, the isocitrate dehydrogenase mutation was found to exist in the majority of low-grade tumors. And we think it exists in probably about 75% of these tumors. And this confers a survival advantage and also provides therapeutic options. There are also single nucleotide polymorphisms which have been found, particularly specifically in chromosome 8. And in those patients, they have a 5-fold risk of developing a low-grade glioma. So coming to the genetic markers, I've divided them into 2. The common ones that you should know about, particularly for the neurosurgery trainees, these are important. That's the IDH1, IDH2, ATRX, which stands for alpha thalassemia mental retardation gene, the telomerase reverse transcriptase promoter mutation, that's the TERT, and the 1p19q co-deletion. Those you should try not to forget. There are a lot of other markers, okay? And particularly when you do gene sequencing, you may see these in the histology reports. If you take time to go through the histology reports, you'll see these things like the BRAF mutations, the histone mutations, MGMT status, which is very important for high-grade gliomas, but there is a role for MGMT in low-grade gliomas, particularly when it comes to recurrence. And then you've got other more research-based tools like CIS, FUBP1, and Notch. And there are different research classifications that are available where you take all these different genes and essentially you can tabulate them. Certainly the Cancer Genome Atlas has, divides low-grade gliomas into 3 groups. But the basic thing you need to understand is that IDH mutation and 1p19q co-deletion divides them, divides these cancers. This slide shows the evolution and development of the molecular knowledge that we have gained over the last few decades. So at the bottom here, you can see probably around 1996, 97, the 1p19q co-deletion was identified in anaplastic oligodendroglioma. And further along, in about 2006, 2007, you've got the prognostic value of the IDH mutation becoming apparent. You know, so this is influencing the way that we're thinking, the way that we're managing patients. The TERT promoter gene comes in about 2010, and then the Cancer Genome Atlas really has identified the different molecular subgroups by about 2015. And this culminates in 2016, where you have the new revised WHO classification. And simultaneously, what's happening is that there are large trials that are being performed. And in North America, the R9802 trial, which looked at radiotherapy. So it looked at patients who had a diagnosis of a grade 2 astrocytoma. So they've either had a biopsy or surgery. And they've compared radiotherapy to radiotherapy and PCV chemotherapy. And so this trial is being done about 1997, I'd say. And when the preliminary reports are coming out at 5 years, looking at 5 years overall survival, the trial reports that actually there's no difference between radiotherapy and PCV versus radiotherapy alone. But after 2015, that same trial, when they looked at the 10-year outcome, they could actually see that there was a clear difference between those patients who received radiotherapy and chemotherapy versus those who just received radiotherapy alone. And then at the same time, when they then applied the molecular classification to that same data, they could now see the behavior of these low-grade gliomas. And you can actually see that they aren't the same. The oligodendrogliomas do much better than all the other categories. And the astrocytomas, which don't have the IDH mutation, do very badly and actually mimic glioblastomas. Now, this trial, there's also a European trial, an EORTC trial that was done at the same time, which looked at the same thing. These two trials changed everything that we do. And I went to a SNO meeting just after the 10-year overall survival results came out. And what we did the next year was completely different. We started offering everybody upfront surgery. So IDH, the isocitrate dehydrogenase, as I've explained, is extremely important. Okay, now there are two types, there's IDH1 and IDH2. IDH, it's an enzyme, and IDH1 is found in the cytoplasm of the cell, and IDH2 is found in the mitochondria. Both IDH1 and IDH2 convert isocitrate to alpha-ketoglutarate. That's their normal function in the cytoplasm and in the mitochondria. When you have a mutation of these genes, you have an reduced production of alpha-ketoglutarate, and you end up producing 2-hydroxyglutarate, both in the cell, in the mitochondria and in the cytoplasm. And it's this 2-hydroxyglutarate that then affects DNA methylation. Okay, so that's like the mutagenic property that's there. So that's quite important. And the way we detect IDH is really in two ways. One is using immunocytochemistry or immunohistochemistry. So with the immunohistochemistry technique, you can detect IDH1 in the cytoplasm, and what you're doing is detecting the antibody to the gene you're looking for. So you can see here there's an H&E stain of an anaplastic astrocytoma, and it is positive for IDH1 using the R132H. Now, you cannot detect IDH2 using immunohistochemical methods. In order to detect IDH2, you have to do gene sequencing or apply a gene panel. And with a gene panel, you'll pick up IDH1, you'll pick up IDH2, and then you'll pick up anything else that you're looking for. Now, the limitation of the molecular diagnosis is that in research, you can test anything and everything that you want. But when it comes to the clinical application, you know, every test that you add becomes more expensive. So what we find is that we will get maybe 3 or 4 different genes tested with the panel that we've chosen, but we don't get every single gene, and then we will change the panel depending on what we're looking for. With immunohistochemistry, you can also pick up the P53 and the ATRX mutation. And with the gene panel, as I said, you can look at BRAF, you can look at histone. And if you're looking at those things in a low-grade glioma, they're usually being looked at in terms of trying to exclude, trying to make sure that it's not a high-grade glioma, or it's not a pediatric glioma. I hope you're still with me. Now, then with 1p19q, this is looking at chromosomal loss, and the test is different. You look at it's something called the FISH, which is fluorescence in situ hybridization, and you're looking for a loss of the short arm of chromosome 1p or the loss of the long arm of chromosome 19q. Now, in the classifications, we look at 1p19q co-deletion, so they need to be there together as dichotomous. It's either there or it's not. In reality, there are patients who have it and those who don't, and then there's some who may lose either 1p or may lose 19q. And we don't really know what that actually means in terms of their survival. They don't have the 19, they don't have the co-deletion, but is their survival any better than someone who actually doesn't have any of the deletions? That's something that we're still working out. So this slide shows you an H&E stain of an astrocytoma and an oligodendroglioma. And again, when I did my exam, you had to be able to pick out the fried egg pattern of the cells, which you can quite clearly see of an oligodendroglioma. But now that's not enough. For an oligodendroglioma, it needs to be IDH mutant, and it needs to have the 1p19q co-deletion. And then when you look at ATRX, most of the time, it should have ATRX. But ATRX is not critical. What's critical is the 1p19q co-deletion, okay? And then for an astrocytoma, this is IDH mutant, but 1p19q is intact. And typically ATRX is lost. So the 2016 classification, WHO classification of brain tumors, is actually an updated version of the 2007 classification. It's not the 5th version, it's still the 4th edition, and we're waiting for the 5th edition to come out, and I suspect there'll be even more molecular parameters in that 5th edition. What's different with this 2016 classification is that the molecular status relating to IDH and the 1p19q status deletion has been added. And then you'll notice that there's a group where you may find after a diagnosis it says NOS, and that means not otherwise specified. What that means is that either whichever bit of the molecular testing has not been done, or the tests have been done, but the tumor doesn't show the characteristic genetic alterations. And this is an acknowledgement to say that our knowledge has improved, but we are aware that we don't know everything. And there's a discussion around revisiting these historical histologies and molecular diagnosis, wherever it says NOS, maybe in 5 years' time, and applying, new techniques to try and understand those diagnoses better. So it's important to be aware, but it means not otherwise specified. So this table here, I've taken this from the paper, David Lewis's paper, which talks about the WHO classification. So from a histological perspective, you've got the old groups, astrocytoma, oligoastrocytoma, and oligodendroglioma. These three used to make up your low-grade tumors. Glioblastoma is high grade, so that's separate. So when you look at the molecular status, you divide them according to IDH, okay, whether IDH is present or not. And when IDH is not present, we call that IDH wild type, okay. What's important to note about the IDH status? If the IDH status is positive on immunohistochemistry, you don't need to do the gene sequencing. But if the IDH status is negative on immunohistochemistry, then you need to do the gene sequencing. And if you can't do the gene sequencing, then actually your tumor is going to go down as an NOS, okay? Because you haven't done enough tests, because we know that the immunohistochemistry is not as specific as the gene sequencing. So for the IDH mutant tumors, you've got those that would have lost ATRX and have the TP53 mutation. They are the diffuse astrocytomas IDH mutant. But there's an asterisk there against these two saying that they're not critical for the diagnosis. So if your ATRX and your T53 aren't quite what you're expecting them to be, if it's IDH mutant, you can still be an IDH, diffuse astrocytoma IDH mutant. If the 1p19q co-deletion is present, then the tumor becomes an oligodendroglioma IDH mutant and 1p19q co-deleted. If we're certain that the IDH mutation is not present, then it's an IDH wild type tumor. So that becomes a diffuse astrocytoma IDH wild type. But it's in this group that other tests should really be applied to make sure that this isn't something else. Because the behavior of this diffuse astrocytoma IDH wild type is that of, it mimics of glioblastoma. They talk about it being a baby glioblastoma. And then in a situation where you do not have molecular testing available, right, or the tests are inconclusive, then your tumor categories become diffuse astrocytoma not otherwise specified, oligodendroglioma not otherwise specified, oligoastrocytoma not otherwise specified, or glioblastoma. Okay. And the thing that this table doesn't show you that you need to take into account is that sometimes the histological appearance may favor glioblastoma. But if you apply the molecular studies and it's IDH mutant and it comes back as co-deleted, you can downgrade from glioblastoma to anaplastic oligodendroglioma WHO3. So it can get quite complicated, but with time you get familiar with the way this classification works. So the main groups that we now have are a diffuse astrocytoma IDH mutant, which is usually a grade 2 tumor, an anaplastic astrocytoma IDH mutant, grade 3. So this tumor looks more active than that one. Then you've got the oligodendroglioma IDH mutant and 1p19q co-deleted. And it is essential for 1p19q to be present in order for it to be called an oligodendroglioma, and an anaplastic version of that at grade 2 and grade 3. So this slide is important to remember. I mean, when you look at survival, because the whole point of a genetic marker is it needs to be of benefit. Either it informs us in terms of survival, or it helps us in terms of therapeutic options. And survival is improved with IDH. Survival is definitely improved with 1p19q. And from the research perspective, we know that survival is very, very good when you have this allele at chromosome 8. When the TP53 is positive, then survival is poor. And if you have a TERT promoter mutation alone, then that certainly has a negative impact. So the standard of care where I'm working in the States, in the UK, in Europe, really regarding a low-grade glioma is to do an MRI scan to identify it. If it's possible, to perform a maximal safe resection, surgical resection. And if you can achieve a gross total resection of the low-grade glioma and your patient is under the age of 40, then you simply need to carry out MRI surveillance. There's no need for adjuvant treatment. Okay, it's a generalization, but actually this is what happens in practice. If your patient is above the age of 40 and you've achieved a gross total resection, you need to consider radiation and chemotherapy. But it's a discussion with the patient, and we don't really know about the timings, because this is very different from a high-grade glioma, where there are timings that are in place in terms of you have your surgery, and from your surgery you go on to have your adjuvant treatment. But if you're dealing with a low-grade glioma, we would recommend that the patient has radiation chemotherapy, but some patients may choose not to go ahead with that straight away, or may choose to have chemotherapy first, or may, Then if you haven't managed to remove all of the tumor and your patient is over the age of 40, then they must have chemotherapy and radiation therapy, because the tumor will just simply continue to grow. And if you've got a patient who's under the age of 40, you do have the option of considering MR surveillance to see what happens, or chemotherapy. And the rationale for this is that, yes, we know that the molecular information for these tumors will tell us which ones are more likely to progress quickly and which ones aren't. And we also know that radiotherapy and chemotherapy work, particularly when you have the IDH mutation or when you've got an oligodendroglioma. But you have to balance the radiation and chemotherapy with the late effects that can occur. And the younger your patient is, the more likely it is that they're going to live for longer. So the longer they live, the likelihood of them developing late effects, either to their cognition or late effects in terms of endocrine function, are higher. And so if you can delay adjuvant therapy for as long as possible, that's probably the best. My most recent example of this is a patient who has a TP53 Lee-Fraumeni mutation, who has she has an IDH mutant tumor, but she had her initial surgery, which was a subtotal resection. But we know that if we give her adjuvant treatment now, well, if she was given adjuvant treatment when she had initial resection, then she would be at risk of other cancers developing as a consequence of the radiation treatment. And she managed to push for 24 months, and then the tumor started growing. So she's recently undergone further surgery. The tumor's all out, and then the debate now is, should we go to proceed with chemoradiation therapy now and accept the risk of late effects, because it's felt that the tumor will continue to grow if we don't treat it. So I have some examples here for you. It's a 42-year-old gentleman who was incidentally diagnosed with, in 2013, with a subinsular tumor. He then went on to develop seizures, and the second scan from 2015 shows you that the tumor has actually increased in size. So he went on to have a stereotactic biopsy. The pathology came back as an astrocytoma grade 2. Now, the IDH was negative, but this was on immunohistochemistry because this is back in 2015, okay? And he went on to have radiotherapy, but he's still alive. So I do wonder, you know, I think the pathology is now, you know, grade 2 astrocytoma not otherwise specified, because what we really should be doing is doing a gene panel on him to confirm that he actually is truly IDH negative. And this is an example of an IDH mutant tumor. There's a 31-year-old lady who is presented with complex partial seizures, and you can see a large right temporal lesion, which is hyperintense on the T2 weighted image. She had a resection. I think she had a small stroke, but that recovered. Her pathology came back that this was astrocytoma grade 2, IDH mutant on sequencing, but the tumor was not co-deleted. And she also had the BRAF and the TERT gene tested, and they were both negative. She went on to have radiotherapy and PCV chemotherapy, which is the standard of care for these tumors. And she's doing quite well. And here is an example of an oligodendroglioma. 47-year-old lady who presented with seizures, went on to have surgery for this subinsular lesion. She had a good resection, made a good recovery. We confirmed the diagnosis of an oligodendroglioma, co-deleted tumor. She went on to have radiotherapy and PCV chemotherapy, but she recurred within a very short period of time. Just over a year, the tumor came back, and she went, and this time the recurrence was frontal. So, but she had further surgery. So what I've done here now is I'll briefly show you our outcomes. So this really is a 10-year, I think it's a 10-year analysis of low-grade gliomas that have been managed in Sheffield. David Eagle, one of my registrars, kindly did this work with the team. And the aim really was to look at our histological diagnosis versus our molecular diagnosis, and looking at outcome to see if, you know, what was seen in the R90802 is what we would see in our historical samples. So everybody included in the study was either a grade 2 or grade 3 glioma with a genetic analysis. We did the FISH, but at that point we were only doing immunohistochemistry, so their IDH status has been confirmed by immunohistochemistry. We then looked through the patient's notes and specifically focused on outcome. The median age for this patient was 45, and there's a 1-to-1 female ratio. So when you look at the groups, so 43% were grade 2 tumors, 57% were grade 3 tumors. When it came to co-deletion, just over a quarter, so 28% were co-deleted. 31% were not co-deleted, definitely. And then remember, I said there's subtleties with co-deletion. We have abnormal results in 16% of patients, and in 37%, we don't know what their status was. When it comes to the IDH, 50% of the tumors were IDH mutated, with 41%, with 28% but were wild type. But again, I would caution you, we didn't do gene sequencing at that time. Looking at surgical resection, 36% had a gross total resection, and 59% underwent radiotherapy, and 23% had chemotherapy. At the end of the study, 67% were alive, and 52% had a progression-free survival. So these two graphs are, so the next few graphs are important, because when you look at overall survival for these tumors, this is by histological grade, there's not much difference between the grade 2s and the grade 3s. It doesn't reach statistical significance. And this is at 6 years, 75 months. And when we looked individually at the 1p19q status and the IDH status, you can see that the 1p19q, so the oligodendrogliomas, not surprisingly, do the best in terms of survival. And the wild type tumors don't do so well. And when you combine all the information we have, we reproduce the graphs that the studies, the large randomized studies were showing. So what you have here is the overall survival by molecular classification, and you can clearly see that the oligodendrogliomas are the group that survive the best, that do the best, with over a 90% survival at 6 years. This is followed by the IDH mutant tumors. Okay, these two groups are, the astrocytoma and oligodendroglioma, but remember, they're not otherwise specified. So we actually haven't, the molecular analysis is not complete. And for the wild, what we think are the wild type tumors, we can see a pattern that's expected, where they clearly do a lot worse. So our work showed us that, the updated classification certainly has improved our understanding of the outcomes. We did do some subgroup analysis with regards chemotherapy and radiotherapy, but the numbers then became too small to draw meaningful conclusions. We felt that gross total resection actually improved survival, and this was most noticeable in the patients with aggressive tumor types. And recommended, like others, that genomic analysis of historic samples would further improve our understanding of the efficacy of treatments in these tumors. So what to do when a low grade progresses? It's quite a difficult question. Here's a young man, 28, who has simple partial seizures, and he has a left temporal tumor, you can see there, and he's had a subtotal resection, wasn't a complete resection, of an anaplastic oligodendroglioma, WHO grade 3. His ATRX was wild type, IDH was mutant, he was co-deleted. He went on to have radiotherapy and PCV chemotherapy as standard of care, but you can see over here that there's progression, and this progression happened within 12 months of his treatment, and you have a remote lesion. So there are a lot of questions in terms of how do we best treat patients like this, who have had maximal treatment, but the tumor still continues to progress. And I've had lots of discussions with my oncology colleagues, and the answer I get is most of these are managed as high-grade tumors. So if they've had PCV, they'll usually go on to have temozolomide. There is a role for repeat biopsies of these lesions, because we do know that the chemotherapy and the radiotherapy do have an effect on the genetics. And understanding this effect, so maybe understanding their DNA methylation status from an MGMT perspective would be very useful to know whether temozolomide is the right thing to give them or not. We consider other treatment options if the recurrence is not in the radiotherapy field, then we would consider giving them stereotactic radiosurgery and look at other chemotherapeutic options. We do look at clinical trials, but they're very few. There's very limited availability for clinical trials for patients with low grades that have progressed. So usually they will end up on a high grade trial. Very briefly, so we've talked a lot about diffuse, these lower grade gliomas in adults. We do see lower grade gliomas in children. Now, I think the topic of low grade gliomas in children is very different because the tumors that we see in pediatrics are very different. Mainly it's pilocytic astrocytomas, and these are grade 1 tumors. You do get grade 2 tumors, so diffuse astrocytomas that occur in children. But take-home message is that they are not the same with adult tumors. The molecular findings are completely different. IDH is very rarely present. The IDH mutation is very rarely present. And just because it's not present doesn't mean that the child is going to do badly. So, the literature says that IDH has no prognostic significance in a pediatric tumor. We do see oligodendrogliomas. However, only 18% of them will have the IDH mutation, and only 25% of them will have a 1p19q code deletion. So the diagnosis of an oligodendroglioma in a child is being made on a histological basis. And the patients who do have the 1p19q code deletion are the adolescents, so the older children. Okay. And you get some changes in the fibroblast growth factor receptor. And the other important thing to know about pediatric low-grade gliomas is that their rate of progression is significantly lower than adults. And as such, radiotherapy is not considered, even if you have not taken out the whole tumor. If there are concerns about progression, then the child is usually offered chemotherapy first. But the vast majority of them will have surveillance imaging. So, have you had an opportunity to answer the questions?
Yeah, we have a few. Before we get to the African context, if you don't mind, I'd like to ask the questions from the panelists.
Mm-hmm.
Okay. The first question is from Gideon. So you mentioned that gene sequencing to determine the genetic makeup of these tumors, for example, IDH1 is expensive. In your experience, is there a specific pattern to IDH1 or 2 tumors on scans or presentations that will reduce this price?
So in terms of scanning, probably 2 slides away from here, I've got some information on biomarkers.
Mm-hmm.
And in fact, we can look at it now because it covers it. So MR scanning is one of the current advances, trying to pick up imaging biomarkers for IDH. Okay, and it makes sense. You said at the beginning, you took away my talk, that the answer in the low-resourced parts of the world is to try and use innovation to get around the challenges that we have. So if there is an imaging biomarker that can tell you that this is a low-grade glioma, then surely, an IDH mutant tumor, then surely that's good, okay? Because it begins to provide you with the information to make a better decision. And specifically, they're looking at MR perfusion and also looking at MR spectroscopy, because remember, if you go back to that slide where I showed you the product of the mutation, the product of your mutation is 2-hydroxyglutarate,
mm-hmm.
and you can pick that up on spectroscopy. Okay, so you can see that at the bottom here. Mm-hmm. So I think that this is, certainly over the next few years, we will be finding out more about this. Okay, And it's not just IDH that they're looking at, there are other markers that are currently under investigation.
Okay.
Okay. Does that answer your question?
That was Gideon's question. I think so. Well, we'll let you continue and ask the others at the end.
So really, you know, with the African context, the first question is really, how accessible are molecular tests to, you know, people that are working in Africa? We know that in Africa, there are a lot of challenges in terms of accessing healthcare. We know that, you know, even simply thinking about a biopsy, so an MRI scan, first of all, a biopsy, secondly, and then thirdly, to actually establish the diagnosis with histology, and then molecular testing. It's so far down the line that the best way around this is to find out from you guys what's on the ground.
Well, thanks. I can give you the results straight away from the short survey. So everyone has access to molecular biology in their countries. However, there are quite a number of barriers. So the first one obviously is monetary, the funding. We equally have the second theme is lack of knowledge. So be it from the patients or even the physicians who are not aware that this is available and that this could be used to take care of the patients. So that's the result from the survey.
So I think that's very positive, because certainly when I've, you know, looked up what's being done to try and standardize treatments like this in low and middle income countries, what I found really is a lot about networks and people, you know, teams working together. So working together to identify where it is possible to get a biopsy, or so possible to get a biopsy and to get the molecular tests, and then to work in partnership with each other, so that even if you don't have a pathologist who can do the test for you, but you know that 300 kilometers away there's a pathologist who can do the test, then that's the way to access the test, first of all. Then the next key thing is education and training, to ensure that the teams, you know, the members of the teams, the pathologists, the medical technicians, etc., are able to carry out those tests. And I understand, you know, things like funding are important, you know, getting governments on board or universities on board to fund such initiatives is important. But I think a lot of it starts with the clinicians themselves to organize themselves. And a good example of this I found was the PSYOP group, which is Pediatric Neuro-Oncology. They've set up a workforce of people who work in developing countries who have come up with a guideline for pediatric glioma management. And that stratifies centers from 1 to 5. 1 being a pilot, you know, someone who's listening to this today and thinking, I want to do this, to 5 being a center of excellence where you have everything. And it's about developing networks across those levels to share information, to provide access to the testing. Because the most important thing, and this I picked up from our own UK NICE guidelines, when they were looking at developing a guideline for us here, the question they asked is, okay, it's all well and good that you've got this molecular test, but does it make a difference for the patient? So you need to have a radiotherapy machine if you're going to do the test. So it's important to understand, you know, the lay of the land, understand where the resources are, and then work together to develop a solution in your area. And if I put a few challenges there, the challenges are cost. The challenges are, you know, the skill and the expertise, and access to adjuvant treatment. one of my colleagues talked to me yesterday, and he said that they had sent a specimen from Nigeria to the States for molecular. And I thought, oh, storage of the fixing and storage and transportation of tissue is so important now, because a lot of these in the adult world, we send fresh specimens to the lab for smears, and then we fix the rest. But when we're in pediatrics, we have actually stopped sending formalin fixed specimens. We will send fresh because they go to the lab and then they're frozen straight away, because some of the pediatric gene panels only work on fresh tissue. So if you send them tissue that's been in formalin, it's useless, you know. So there are a lot of considerations that teams need to take into account to make it possible for their patients. And as you mentioned before, so novel innovation, very important. The MR spectroscopy we've talked about. And there's something called liquid biopsy. I think I put something about this a little bit later. So the future is bank tissue, okay? Even if you don't have access to the test, bank tissue, because I think in 5-10 years time, you will have access to the test and you can still do the test then. So tumor banking is very, very important. Collaborating in terms of research is important, because universities provide a way of getting this, you know, these complex investigations done. My dream is to have a rapid bench test at the time that I'm doing the operation, because with low-grade gliomas, they occur in difficult areas. And sometimes I think to myself, do I need to take 100%? Or can I get away with taking 90 and my patient has got no deficit? And if I know that I'm dealing with a co-deleted, you know, with an oligodendroglioma, then I'd rather take 90, right? Then we watch, and then he can have radiotherapy or chemotherapy, than try and take 100 and he has a stroke, you know. So I think having a rapid bench test is very important. And liquid biopsy. We go to these meetings and there's a lot of discussion about the products or byproducts of these tumors that enter the circulation. Is there a way of monitoring the tumors from blood tests? And we may be able to use this to look at the response of the tumor to treatment, or to look at recurrences. We've talked about that. So in summary, I would say genetic markers improve the diagnosis. They help us explain the prognosis to our patients much better. And I think that they provide much better therapeutic options for our patients. Thank you.
Wow. Thank you so much. Thank you. We have a few questions from the attendees today. So the first one up is by Dr. Ola. So here's the question: are there chances for only one arm of those chromosomes to be deleted? If yes, what happens? I guess this is in the co-deletion.
Sorry, I didn't get that. So are they?
Is there any chance for, in the case of the 1p19q co-deletion, is it possible that you have only one arm that has a deletion? And if that's the case, what happens?
Yeah, so we do see it. We see either a 19p deletion or we see a 1p deletion. I can't remember which it is. There's one that we know that the survival advantage is better than a tumor which has no deletion at all. And then the other one, it doesn't. But when you read the papers, to be fair, we're still discovering more, okay? And the other thing to say about that is one of the papers said that actually when you have one arm that's deleted and the other one hasn't, that's usually a marker of transformation. So as opposed to being a good prognostic sign, it may actually be the opposite of that.
Okay, thank you so much. And then a follow-up question to that is, do we know of any specific triggers to these deletions?
No, not that comes to mind. You might have to ask a proper scientist that one.
Okay.
But I do know that there's a lot of work that goes into epigenetics, and perhaps that may be the answer. You know, that there's some epigenetic change that then triggers a change. So I did read something about, you know, temozolomide, that temozolomide actually induces changes. You know, so there's a lot of there are studies which have been looking at temozolomide in low grade patients who aren't co-deleted, with some studies saying it helps and other studies saying it doesn't. And the ones where they say it doesn't help is they're saying that actually it makes the tumor more unstable, you know, or the residual tumor more unstable.
Okay, thank you so much. The next one is from Rosaline. Do you tend to prescribe PCV over TMZ?
So our NICE guidance for low-grade gliomas prescribes PCV. Okay. There is some evidence now to support using temozolomide in patients who are IDH mutant but not co-deleted. Okay, but not everybody does it. But in recurrences, they will tend to use temozolomide. That's from my experience of sitting in the meetings and talking to my colleagues.
Okay, thank you. This is a question from Gideon, which is actually a follow-up from the very first one. So what is the mechanism behind the IDH1 mutation, behind the IDH1 that confers a better prognosis? And what does increased 2-hydroxyglutamate actually do?
So I know the answer to the second one. What 2-hydroxyglutamate does is it causes DNA methylation. You know, it alters DNA methylation, which then has a negative effect. In terms of how IDH actually confers a survival benefit, I'm not sure.
Okay. And this one from Rosaline, what are your thoughts on the IDH inhibitors in the development of IDH mutant tumors?
As in to stop the tumors from occurring in the first place?
Maybe she can.
I'm not sure.
Yeah, it was. So I guess that is the direction she was headed when she asked about that maybe in the medical treatment or.
Did she referring to any specific inhibitor?
No, just no. Maybe Rosaline, you can specify in the chat. Okay, so she wrote, I'm sorry, I meant there are some clinical trials looking at the IDH inhibitors as treatment for IDH mutant tumors. So what are your thoughts on this treatment?
Okay, does she know specifically what they are? Because Rosalind, I'm a neurosurgeon, not a neuro-oncologist.
Yeah. Well, I guess she can add that there. So Olaoluwa Ezekiel asked, you mentioned that there are other markers, but you explicitly spoke about IDH. Does that mean that IDH is the most he says effective, but I guess it's the most potent, we'll say, among all those mutations?
So it's the most, I think it's the most relevant. So the two are the IDH and the co-deletion. So we know that most low-grade gliomas have the IDH mutation. And we know that the IDH, low-grade glioma with the IDH mutation behaves better and responds better to treatment. And we know that a patient with an IDH mutation and the co-deletion responds the best, both in terms of survival and to treatment, and specifically to radiotherapy and PCV chemotherapy. So I think the thing to understand is that there is a lot of research in the background. There's loads and loads of research, but not all research makes it to clinical practice, Not all research gets to that phase 3 trial. And here we have an example in medicine where you've got to the phase 3 trial, and the phase 3 trial has actually shown you that the research matters. And we can change our clinical guidelines for the management of these patients, which is why the WHO classification was updated to include IDH and the 1p19q clone deletion, and which is why you then have clinical guidelines, like here in England, we have NICE guidance in terms of how to then go on to treat these gliomas. So in answer to your question, yes. And that's why I said that there's so many, you know, I can fill the slides with little letters and little numbers. But the thing that's important is to understand the role of IDH and to understand the role of the code deletion. That's key.
Yes, thank you so much. I mean, I agree with you, and we had there was a webinar a few days ago during which a lot of the neurosurgeons and neuro-oncologists were saying exactly the same thing, where we have a lot of promising drugs and promising clinical trials, but they don't always translate to clinical benefit. And some of them were actually asking about the potential of even sometimes combining some of these treatments, but it's difficult because the industry, the pharmaceutical companies will not really like that. So yes.
I think you I've been to Snow about 4 times now, and you go to Snow, and each time there's a new trial or a new drug on the market, and you think, wow, this is it. You come back the next year, they don't exist, and you wonder what happened, you know. And so there's a lot of research, there are a lot of drivers, a lot of stakeholders, but here we have something that actually works.
Yeah. I think we can get maybe 2 or 3 more. So Gideon asked, is there a role for ML in biomarker detection for low-grade glioma, or is it not viable?
ML?
Gideon, can you specify it? Just oh, machine learning. Oh, okay, yeah, or AI, yeah.
I think that there probably is a role, because remember, a lot of these things are driven by data, okay? And the more data you collect, it's then a question of being able to process that information. And when you look at people developing phase 1 trials, they literally, it's almost like they pluck an idea out of the air, you know, and say, oh, well, why don't we try this? And certainly I've been quite skeptical in thinking that really doesn't make sense. But when you look at how the things that are working, the mechanisms by which they work now, what the thoughts that the basic scientists have in the first place to come up with those ideas are not so far-fetched. But the question is, when you get all of that data, are you able to interpret it? And I suspect that a computer would be better at interpreting it than individuals. So I think in answer to your question, the answer is yes. So even when you look at liquid biopsy, you know, they're looking at microvesicles that a tumor is producing. Surely the information that you're going to get from those microvesicles is going to be so voluminous, you know, that having some advanced, you know, AI technology to process that information would be useful. You know, so in the operating theater now, you can get 3D segmentation of anything. 10 years ago, we couldn't. But that machine is actually doing, you know, is providing more precision for the work that we as human beings then subsequently do.
Thank you. This from Dr. Emma Chang. You mentioned how great the rapid bench test would be. Are there any promising ones currently in development?
No, I'm afraid you might. No. No. I think at one Snow meeting, I heard someone talk about it, but it, you know, the biggest problem we have even in Sheffield right now is immunohistochemistry probably takes about 5 days to come back, right? So we know that in 7 days' time, we will have a histological result and some of the immunohistochemical results. But in terms of gene sequencing, it takes 2 to 3 weeks for that information to come back. So yes, I think first process is having the facility in-house, number one. But then it's all the prep that needs to occur to the specimen, and then you get all technical there. I don't think it's impossible, but we're probably a long way off from it.
Wow. Well, thank you. As you can see from all the questions, it's a very stimulating and interesting topic. Everyone has a question about this.